Good evening. Thank you for joining us for this information session about heartburn. My name is Chris Courier. I'm part of the marketing and communications team at Northern Light Eastern Maine Medical Center, and I'm here to help facilitate this session today. We do have a few housekeeping tips to begin, to share before we begin. So during this Zoom session, everyone will remain muted except for the presenters. Feel free to type your questions into the chat window and questions will be answered at the end of the session. Today's agenda will include a heartburn presentation by Dr. Daniel Hetherman. Also on hand during this information session is our Heartburn Program Coordinator, Zena Black. Zena will also be monitoring our chat window during this session, and she's going to share questions with Dr. Hetherman to answer as well. Zena's information will be shared at the end of this presentation, so if you have any questions, feel free to send her a message by email or give her a call. Also at the end of the session, we ask that you fill out a survey. It lets us know how we did and what we could do better, and we really appreciate your feedback. So now here to introduce our surgical team is Zena. Zena, if you want to unmute, please.
Apologize. Thank you, Chris. I apologize for that. The first member of our team that I'm going to introduce is Dr. Michelle Toder. She started her higher education here in Maine, getting her Bachelor's of Science at Colby College. She went on to medical school at Massachusetts and completed her residency at the University of Chicago. She's been practicing general and bariatric surgery for more than 20 years here in the Bangor area, and she is the medical director of our Northern Light Eastern Maine Medical Center Surgical Weight Loss Program. And she's also the co-director of the Northern Light Medical Weight Management Program. Dr. Toder has been a pioneer and a champion of robotic surgery and is the clinical lead for the computer-assisted surgery program. She's been teaching advanced surgical techniques for years and has overseen the growth and development of our world-class surgical weight management program. Secondly, on our team, I'll introduce Dr. Matthew Charbot. He earned his medical degree from the University of New England and completed his general surgery internship and residency at MedStar Washington Hospital Center and MedStar Georgetown University Hospital. He received fellowship training from Albany Medical Center in New York, studying advanced gastrointestinal, minimally invasive, and bariatric surgeries, as well as robotic abdominal wall reconstruction. During his tenure at MedStar Washington, Dr. Charbot held the administrative chief resident position and received numerous awards and accolades. Dr. Charbot specializes in minimally invasive, laparoscopic, and robotic-assisted surgeries. He also specializes in complex hernia surgery, abdominal wall surgery, and also weight loss surgery. Tonight's presenter is Dr. Daniel Hetherman. He received his medical degree at the University of Massachusetts Medical School, where he completed his internship and residency in general surgery at the University of Massachusetts Medical School, Department of Surgery. He provides comprehensive evaluation and management of gastroesophageal reflux disease, also called Gerd, hiatal hernias, gallbladders, hernias, and general surgery. Dr. Hetherman works with patients to create an individual plan of care. Please join me in welcoming Dr. Hetherman to our seminar tonight. Thank you very much.
Hi, everybody. Thanks for coming. Appreciate you guys taking the time. I'm going to backtrack. I was just trying to give you guys some nice, beautiful photos of my partners who couldn't be with us tonight. For those of you that don't know, Dr. Toder is currently biking across the country. It's taking 4 months doing something that I would never want to do, but she's having a ball. So she was featured. They featured her on the local news here, back before she left, and she's making progress. She started in Bar Harbor, put her wheel in the water, and then set out across the country. And she couldn't be with us tonight because she's somewhere in the Rocky Mountains, I think. And Dr. Charbot couldn't be with us, unfortunately, had a family emergency this week. And so I'm left solo, but I'm going to do my best to answer all your questions, kind of talk to you guys a little bit about heartburn. And I'm just going to delay just a minute or two. I'll just give people just a chance to trickle in, just in case we have a few little stragglers. And then I'll go ahead and give you guys this talk. It shouldn't be too long, try and keep it brief and give people a quick, overview of what GERD is and what we hope to offer and kind of what our options are and where we go from there. So I'll hang out for a minute and then I'll kind of get going. All right, well, it looks like we picked up a couple more people. So I'm gonna go ahead and get started. So you will see a bunch of photos in this presentation of various different people. There we go. Obviously, we're doing things virtually, A, because it's a lot easier for a lot of people to join us from anywhere they are. And B, obviously, with the pandemic, we kind of changed gears on how we do a lot of these things. A lot of the pictures are pre-COVID-19, so they might not be wearing masks or stuff in medical settings. But we appreciate you for coming and taking the time. And I always tell everyone, this is general information. Every individual is going to have their own story, their own history, surgeries before, their own specific factors that are going to influence their treatment plan and the best options for you. But this is designed to give you a kind of a general overview of what GERD and heartburn are and sort of what the various treatment options are. So without further ado, I'll kind of give you our my little talk here. So these are our group of surgeons here. I kind of mentioned these a little bit a second ago, and Zena gave you guys a great intro. So Dr. Toder has been here for quite a long time in Bangor doing robotic surgery, and she's one of our heartburn specialists, as well as Dr. Charbot and myself. We recently were accredited as a center of excellence for robotic surgery and hernia surgery. Myself, Dr. Charbot, and Dr. Toder all were designated surgeons of excellence as well. So we're really proud about that and glad that we could get that accreditation. So what is GERD? Well, GERD is essentially the process of stuff that goes down into your stomach, coming back up into your esophagus where it doesn't belong. And there's various reasons that it happens, but that's the fundamental fact of that's what it is, right? Stuff that's supposed to stay down in your stomach, but isn't. And that gives us a variety of symptoms. And GERD is super common. 2/3 of adults will have it during their lifetime. I'm surprised it's only 2/3, to be honest. And over 4 million visits every year to the doctor to talk about GERD. So what symptoms are common? Well, the most common thing we see is what's called typical heartburn, right? Burning chest pain. You just feel that burn right there in the chest after eating. You eat something spicy, some garlic, maybe you have a drink, something that's going to set you off, and you just know it's going to be a rough night. Some people have more abdominal pain. Some people have more chest pain. And then they're sort of get into different things. You can have sometimes trouble swallowing, maybe an acidic taste in your mouth if your stomach acid's coming all the way back up. You can also have what we call some atypical symptoms. You can have hoarseness of your voice, frequent swallowing, or feeling like you need to clear your throat. Some people even have coughing or asthma because of their reflux. If it's bad enough, it can cause dental erosions and also irritate the throat. So what are some of the risk factors for developing heartburn? Number one tends to be diet, right? Like I said, you eat that spicy meal, you eat that pasta sauce, with the garlic and onions, peppers, and you kind of know it's just going to hurt. So that's first and foremost, oftentimes what triggers most heartburn. Then there's other risk factors as well. Smoking, anything that irritates the lining of your esophagus and your throat is going to make any sort of reflux that happens worse. Obesity. So I kind of talked about the process of reflux, right? Is that things that are in your stomach kind of going back up or into your esophagus where they don't belong. When we have more weight on board, then there's more pressure on our stomachs, basically from our abdomen, that pushes things back up. And that's going to increase the amount of acid reflux we have. Pregnancy. So for all the women in the room who have had babies, they probably are well aware of this, but not only do you have a weight pushing up on your belly, but you also have all the hormones that actually loosen up the ligaments and actually make you much more prone to get reflux. And lastly, hiatal hernias. And I'm going to I'll talk a little bit about that later as I kind of talk a little bit more about things. But the hiatal hernia is essentially a weakness in the diaphragm, right, where the esophagus comes through and changes over to the stomach. And that can stretch out, and that makes people more prone to having acid reflux. So how do we diagnose GERD? Well, most of the time, GERD is actually just diagnosed by talking to your doctor, right? It's pretty simple. It's, doc, I eat these things, I get this burning pain, like what is it? Well, most of the time it's heartburn. But sometimes we do other tests. Oftentimes when patients come to see us in the surgery department, we start talking about doing different type of testing. And that's mostly just because we're talking about doing different types of things. So endoscopy, so some patients will have an endoscope, which is for those who have had a colonoscopy, similar, right? We take a scope, but instead of going from the bottom, we go from the top. We go through the mouth and we take a look down at the esophagus, the lining of the esophagus, the lining of the stomach, and the small intestine. And that can kind of help us diagnose GERD. We can do biopsies, we can see signs of inflammation, various different things that can help us determine what's going on. Sometimes we do what's called an upper GI, where basically you take some pictures. Basically, we have you drink a little contrast and we shoot some pictures, x-rays as the contrast goes down. And that can show us if you have a big hiatal hernia. It can show us if there's a lot of stuff coming back up. The contrast goes down and then comes right back up. We sometimes do other testing, which we actually do a pH probe. We put a probe down there and actually measure how much acid comes back up. Sometimes we do that if we need to. Other times we'll do testing such as imaging with a CAT scan or other testing of the stomach and esophagus. So as we kind of talk about more anatomically what causes reflux, I mentioned this a little bit before. So there's sort of two mechanisms that we have to sort of prevent reflux normally. Normally at the end of our esophagus, there's something called the lower esophageal sphincter. It's basically a little valve. And what happens is when we eat so normally that valve is closed, right? So normally your stomach, you've eaten something, that valve is closed, and that helps prevent stuff from coming back from your stomach into your esophagus. When you swallow, that opens up, that lets things through. So sometimes you can have reflux because that sphincter is just not working well, right? It's just kind of open, it's not really closing well, it's a little weak, whatever it is, that can be what predisposes some people to having acid reflux. And it can also be hiatal hernias, like I mentioned. So you see here on the left, there's the diaphragm, this little thin gray line, and that's the esophagus. It comes through the diaphragm and into the stomach. Now, if that opening gets wider, the stomach can sneak up into the chest. And what that does is it sort of takes away some of the resistance to acid reflux. So people with hiatal hernias are more prone to acid reflux than someone without one. It doesn't mean that if you have acid reflux, you have a hiatal hernia. And if you have a hiatal hernia, it doesn't necessarily mean you have reflux. It just means it's sort of a risk factor. So what are your general options when we talk about treating GERD and heartburn? Well, it's sort of divided into three categories. So the first is lifestyle modification. When I see patients in the office, I talk about all three of these. And lifestyle modification is actually really important. A lot of patients can treat almost all of their symptoms if they were with lifestyle modification. Now, it's not always stuff that people want to do. It's not always stuff that's fun, but it is an important thing to talk about. And when we talk about what lifestyle modification means, what we're talking about is certain things like avoiding trigger foods. So if you know that you eat spicy, food and you get heartburn reflux, you can either try to prevent it by taking a medication before you're eating that meal or not eat that meal, and you probably won't get heartburn. The other things we talk about are quitting smoking if you're smoking, losing weight, because we know that every 5 pounds that you lose can actually decrease significantly the amount of acid reflux you're having. We talk about different things like not eating late at night, sleeping sometimes propped up on pillows if people get heartburn at night, various different strategies to try and reduce the amount of symptoms people are having. And the next category we talk about is medications. Well, medications, there's a wide variety out there. Most commonly, they kind of fall into two categories. There's sort of the quick relief medications, Tums, Rolaids, that kind of stuff. And then there's more preventative medications, and they kind of have two different categories of that. But most commonly, people take medications such as omeprazole, Protonix, which is esomeprazole. There's a big family of them that we call PPI, proton pump inhibitors, and they all basically knock that acid way down and really try and reduce the symptoms and reduce the amount of acid that comes back up. And lastly, when we talk about treating heartburn, we talk about surgical options. Obviously, I'm a surgeon, so these are the type of things that I do. And when we talk about surgery, what we're essentially talking about is taking the stomach, we fix a hiatal hernia if it's present. So we take the stomach, get it back down where it belongs, and then we're going to wrap the stomach around the esophagus. And what that's going to do is kind of bolster that valve that was there that maybe wasn't working very well to help make things a little bit tougher for things to go back up. So why heartburn surge? Primarily, it's to relieve your symptoms, right? You do this because you're not feeling good. Maybe the medications aren't cutting it. Maybe you want to get off medications, whatever it is, but you want to feel better, right? That's why we do this. We try and pick the patients that we know are going to feel better when we do these types of things. So it's get rid of your heartburn, get rid of your chest pain, get rid of the sore throat, coughing, asthma, whatever it is that seems to be related to your acid reflux. Maybe you're doing it because you come off your medications. So almost every patient that has an anti-reflux operation will come off their acid medication. We know that in the long run, roughly 20% of patients that get these operations may end up back on their heartburn medication in the long run, but most patients are coming off and staying off their medications for the foreseeable, if not indefinite future. Sometimes we do it to prevent GERD-related complications. Well, what does that mean, Dr. Hetherman? Well, when you have a long-term acid reflux with acid coming back into your esophagus, different things can happen. You can get strictures, which would be a narrowing of the esophagus from scarring. And sometimes we have to dilate those. You can get ulcers, right? Acid comes up and irritates things. And you can get what's something called Barrett's esophagus, where you kind of get changes in the lining of the esophagus. Now, Barrett's esophagus is what we consider a sort of like a pre-cancerous state. It's the cells have changed. They're not cancer yet. They may never become cancer, but we need to watch it because sometimes it could become cancer in the long run. So what is GERD surgery? So the basics of GERD surgery are essentially this. We, like I said, bring the stomach back down where it belongs, right? So we get this is the diaphragm here. We take the stomach, we pull it back down out of the chest. We stitch the diaphragm closed like it should be. And then we basically are going to take the stomach and we wrap the stomach around the esophagus. Now, there are different types of wraps and stuff. This one's called a Nissen fundoplication. It's named after a guy named Nissen. And there are different varieties. I could describe this one to people as, the pig in the blanket. There's another different one that's called a toupee, which I describe more as the hot dog in a bun. But there are different varieties, and each patient, depending on their individual symptoms and risk factors and age and different factors, may be better for a different type. But the basics are essentially, right, we're going to fix your hiatal hernia, then we're going to do a wrap to repair that valve, and also kind of give that repair a little bit of bulk so that hopefully things stay where they belong. So how can these surgeries be repaired? Well, traditionally, things are done with open surgery. And nowadays we do much more things with minimally invasive surgery. So that kind of is robotic or laparoscopic. Those are both very similar. It has to do with basically making small cuts in order to put our instruments into the abdomen to avoid making the old school incision where we had to make a big cut all the way down your belly in order to do some of these bigger operations. Nowadays, we're able to do these types of operations through 4 or 5 very small cuts and use the robot to help us get patients healthier faster. So what are some of the benefits of minimally invasive surgery? We know that patients have less pain, faster recovery, earlier return to work. They spend less time in the hospital, right? People don't want to be here. And it lowers the need for different narcotic pain medications and all sorts of things, which we know in the opioid epidemic is a really important thing that we need to try and work on. Well, what does the robot look like? So here at Northern Light, we are, like I said, a robotic surgery center of excellence. And we actually have 4 of these Da Vinci robots. So we have 4 what are called the XI. They look exactly like this. And basically what we have is little instruments on each of these arms that we can go in on the inside, and it gives me a little wrist that lets me move in ways that I can't with traditional laparoscopy. So it just makes the surgery easier for me to do. And, I used to do this surgery laparoscopically before using the robot, and it's fundamentally the same operation, but I think it's just easier to accomplish with the robot. And I think my feeling is if it's easier for me to do, it's got to be a better operation. So as with everything, every surgery has risks. So for hiatal hernia repair, we talk about a few things. There are always risks that these hernias can come back. I describe it a little bit like this. When we fix a hiatal hernia, it's gotten bigger and we have to shrink that hole down. But we don't want to make it too tight because then you're not going to be able to swallow. And we don't want to make it too loose so the hernia comes back. We kind of got to find that Goldilocks size. And that's the sort of the art of these surgeries, is finding the right size. Because we don't want to have the hernias come back, but we also don't want to have people have trouble swallowing. There's some nerves that are in this area that can be injured. Obviously, the esophagus and the stomach that we're working on can be injured. So there's all these stuff in the area that can be disturbed. But we do our best to make sure that we're doing things safely with the lowest number of complications as possible. And obviously, with any surgery, there's always risks of serious injury, and every individual's outcome will depend on numerous factors, including their patient characteristics, prior surgeries, and other diseases that are going on. So I'd like to finish up by saying, every patient's unique. Talk with your primary care, talk with one of us here in the office, and figure out what's best for you. And then I will happily take any questions. And what I'm going to go ahead and put up this slide. This is our Heartburn Coordinator, Zena's contact info. I'll go ahead and leave that up. And if people have questions, feel free to type them in the chat. I can go back and talk about something more. I can elaborate on different things. Happy to answer questions. Obviously, if they're very specific to each individual patient, I'll have to kind of answer as best I can, but feel free to type away if you have any questions. And thanks for listening. All right. What are the I'll try and read the questions out loud. So what are the risks of staying on GERD medication? So each individual medication has different risk profiles, and each patient should talk about those with their primary care physician. But generally speaking, when we're talking about GERD medications, we're talking about PPI medications. So those are omeprazole, also known as Prilosec, Nexium, Protonix. There's, like I said, there's a whole laundry list of those medications. There has been some press about certain risks, including bone density, kidney disease, potentially dementia. And my sort of summation of a lot of that data is that these medications, generally speaking, are very, very safe. They've been taken for a long time by a lot of people, but individually, they may not be appropriate for certain people. So if, say, you have a problem with your kidneys and you can't be on a certain medication because of that, sometimes we actually do surgery for those patients because the other medications aren't taking care of their disease, or something like that. So there are some risks, but those are a little bit need to be tailored individually. And there's people who just don't want to be on these medications long term, and that is a reason sometimes we do these surgeries. But it's important to have each of those conversations sort of at an individual level. What is typical recovery time for hiatal hernia repair? So typically patients will spend one night in the hospital. Some patients go home the same day, but that's generally for patients who have very, very small hernias and not a lot of other medical problems. But generally speaking, people will stay one night in the hospital. And then if they're doing well, we send them home the next day. Because of the way this surgery is, where we're fixing hiatal hernias, working on the stomach and the esophagus, it's oftentimes a little hard to swallow the next day after surgery. So we put patients on a modified diet. So we expect that you'll start out with liquids and then work your way up to more solid foods. And it can take a couple of weeks to really start eating normally and completely again. But as long as patients are tolerating liquids and stuff like that, we'll get them home, have them advance with our sort of guided diet at home, back up to a normal diet, usually within a week or two. In terms of just like overall general recovery, I say patients are usually sore for a couple of weeks, somewhere in that range. It's a little bit variable. Everyone's a little bit different. It's usually more the incisions that hurt than anything else. And we ask patients not to do a lot of lifting for about a month. So we don't want you doing any heavy lifting because we want that hernia repair to heal and scar before you put a lot of pressure on your belly and try and force that stomach back up into the chest. I think normal release time from surgery, I think it kind of just answered that. So I'm going to if you have a more specific question, then feel free to type it again. Is there a longer number of years? Yeah, sorry. Is a longer number of years with GERD create a complication with the surgery versus someone with a short history of symptoms? No, it doesn't really matter in terms of the duration of GERD changing the surgery, because I'm going to go back for a second. I'll kind of show you. You know, primarily the surgery is on the outside of the stomach and the esophagus, and the GERD effects are primarily on the inside of the esophagus. So, you know, it's most of the inflammation from the reflux is actually on the lining of the esophagus, and all the surgery we're doing is really on the outside. So, you know, the duration of symptoms doesn't necessarily impact things. Sometimes it means you might have a bigger hiatal hernia, sometimes not. Like I said, so it's a little hard to. The hiatal hernia or other surgeries are going to be a bigger impact more so than the duration of surgery. Forgive me for asking, but how many of these surgeries have you done? I've been here at Northern Light Eastern Maine for 4 years now. I do over like 25 to 30 of these a year. And that's about the same for each of my partners in terms of how many a year we're each doing, roughly. It actually might be more than that now, but it's roughly in that. And Dr. Toder is the most experienced. She's been here for 25 years. But Dr. Charbot and I have both been here for 4 and 3 years, respectively. So generally speaking, we've all done a lot of these, is I guess the short answer. Is age a consideration? Yeah, so age is a consideration insofar as patients who are older also have, well, age is just a number. Let me put it that way. So if you are 80 and have very few health problems, but have terrible GERD and want to address your GERD, we're willing to do it. If you're 80 and have multiple other medical problems, it might not be the best choice. But we're always willing to have that conversation on an individual level. So it's a consideration only in the sense that like it might impact other things, but it's not necessarily an issue in and of itself. We've done these on elderly patients. We do these on younger patients. It just depends on an individual's risk factors for surgery and ability to tolerate surgery. What treatment do you offer if someone doesn't have a hernia? If there's no hiatal hernia, and I'm going to put this a little bit in air quotes, because essentially what happens is when we go in to do these surgeries, if someone has no diagnosis of a hiatal hernia, even when we get in here and do the work of freeing up this area and dissecting out this area laparoscopically or robotically and freeing it up, there's always a little bit of a hiatal hernia that we have to fix. So even though there's not necessarily a diagnosis of a hiatal hernia, the surgery itself is essentially the same. It's just that in patients whose stomach has gone up into their chest, we have to do a little bit more work to get that down where it belongs and dissecting all that hernia stuff out. But fundamentally, the surgery is the same. If PPIs don't seem effective, but heartburn is well controlled with Tums, is there any reason to consider surgery? It's entirely up, I will say two things about that. So, I always tell people that patients who do the best with these types of surgeries tend to be patients who've responded at least somewhat or well to medications, such as PPIs, because it's a pretty good sign that the acid is the problem. Now, sometimes we need to do additional testing just to figure these things out. But I generally tell people, if your symptoms are pretty well controlled with just Tums, maybe you don't need to do surgery. Not usually, it's up. There's many different factors that play in the decision making for surgery, and it's hard to answer it just based on that. But certainly it's a possibility that surgery is not the right choice, or it's possible that surgery might be beneficial, but it's a little hard to say with just that piece of information. What is long-term follow-up care, etc.? So basically what we usually do is we see patients a couple weeks after the operation, just checking on how you're doing, making sure you're feeling okay. Part of what we have with Zena being our program coordinator is, the ability to reach out to patients after they've left the hospital. She reaches out to them, making sure that they're doing okay, questions about their diet, just checking in to see how they're doing. After that 2-week follow-up, kind of depends how you're doing, but generally speaking, you're doing well. Then we had basically a follow-up at 3 months where we do a phone call and we just check on how your symptoms are doing. So we kind of do a whole rundown of all your symptoms before, then we do that whole same rundown at 3 months and we kind of see how you're doing. And then we do, if you're doing well, assuming there's no issues, we do the same thing at a year and see how your symptoms are going. If at a year you're doing well, your symptoms are still well controlled, not having any problems, we kind of say you're good to go. You don't really need any annual surveillance beyond that. But sometimes the patients have, and then we basically say if symptoms return, right? So if you start having issues again down the line, whatever it is, we want to know, then we see you back and can initiate evaluations as needed. But generally speaking, after that first year, if patients are doing well, there's no specific long-term follow-up. Does insurance cover the surgery? Yep, absolutely. Definitely a covered insurance. Obviously, everyone's insurance is different. What their insurance covers in terms of cost and what their out-of-pocket expenses are is going to be different for everybody. I tell people I'm a little blissfully ignorant of most of that, but generally speaking, these things are absolutely covered surgeries that patients get done. Is there any recommended physical therapy after surgery? No, not necessarily. Not unless there's something specific, but no recommended specific physical therapy. Zena, are there any questions that we can ask typically that I haven't answered yet that I'm?
The only other thing I might add is that we do work very well with our gastroenterology department.
Yep. So we oftentimes for patients, especially ones who have complex problems, we do have a multidisciplinary meeting with our gastroenterology colleagues to get them involved when sometimes we need them. But yeah. Yeah, most insurances cover these. I'll never say never with anything in medicine, but for the most part, knock on wood, never had any issue like that.
Since I've been here, doctor, we haven't had anybody be denied.
Yeah, not for that kind of thing. Every now and then, they might tell you need to see. Never. The short answer is no. The short answer is yes, they are covered, and we don't really have any problems with these. So I kind of just reiterate saying, if anyone has specific questions, we're always happy to see you, whether it's myself or one of my partners, and see you in the office, do a consultation. If, it's surgery is the right thing, we're always happy to go down that path. If it's not, then I'm always happy to tell you that too. And happy to talk to you about these things and get you feeling better, because that's always our goal, whether it's surgery or not. And I'd like to thank you guys for taking the time and listening, and appreciate you guys coming in today, and enjoy the rest of your evening. And if there's no more questions, we'll let you guys get out of here.
Thanks everybody for joining us. If you have any questions, please do reach out to Zena. Dr. Hetherman, can you just put it on that slide one more time? Thanks so much.
Oh, there's one more question.
Yep.
Do you want me to read it?
No, basically the question summed up is I've been on meds for 8 years, come off it for a few days, it comes back. Hard to say whether to recommend it or not. Again, this is a very individualized question. So obviously you've been prescribed a certain medication. And certainly being on these medications long-term is not unreasonable, but if you want to have a further conversation, I'd have to say, talk to your primary care if you think it's, I wouldn't really wager any specific medical recommendations. I can't really do that. Sorry.
Thank you, Dr. Hetherman, for your presentation, and thank you, Zena, for helping out with all the good things that you do. Without any last questions, I think that we'll say good night, and thank you all for joining us.
Thank you, everybody.
Thank you.